وهو حاصل الماجستير الدكتوراه من جامعة القاهرة، من خريجي جامعة صنعاء طبعا الدفعة الثالثة. ما نشيش نكبر عمره لكن لا زال شاب من الفعالين في الجمعية. موضوعه شيق جدا، Novel Strategies for Glycemic Control and Preventing Diabetic Complications, applying the non-clustering-based classification of adult onset diabetes. تفضل يا دكتور. Time is 20 minutes.
Today we speak about the normal treatment of diabetes mellitus. والسؤال هنا, is the current treatment is depending on the what's called an evidence-based medicine or not? Actually, the current treatment depends on either the presence or absence of atherosclerotic cardiovascular disease or heart failure or the presence of risk factor. Also, it depends on the risk of hypoglycemia, depends on the presence or absence of obesity, and depends on the cost and in the patient preference. But they neglect the etiology and the pathogenesis of diabetes mellitus. The etiology and pathogenesis of diabetes mellitus is important for prevention strategy. This is the first one, and the second, it is important for choosing a proper treatment, and it is important for expecting a long-term complication according to the etiology and pathogenesis of diabetes. In order to achieve this, any newly diagnosed diabetic patient should be subjected to the following: clinical care assessment, this including the age and the presence or absence of obesity. The second is the laboratory assessment, and this including the assessment of the HbA1c, assessment of the presence or absence of autoantibody, assessment of insulin resistance by what's called homeostatic model assessment insulin resistance, and assessment of the beta cell function by measurement of the serum C-peptide level. So any patient newly diagnosed should be suspected to all this investigation. Do any one of them do this investigation? Actually, no. According to this clinical and laboratory assessment, now diabetes is classified in before type 1 diabetes. Now it is called severe autoimmune diabetes, and this accounts for 6% of diabetic patients. It is characterized by the presence of positive glutamic acid decarboxylase antibody. The importance of this is the LADA. LADA, there is misconfusion between LADA and type 2 diabetes. So nowadays they say any patient with positive autoantibody should be treated with insulin in order to prevent a progressive destruction of the beta cell of the pancreas. This is very important. Type 2 diabetes, as previously called type 2, nowadays according to the A1C body mass index with age, is classified into a patient with severe insulin deficient diabetes. which account for 18%. يسموها ketosis prone diabetes. But actually it is an severe insulin deficient diabetes. This patient may present to you for first time with ketoacidosis because of transient beta cell dysfunction. But the auto-antibody of this patient is negative. So you can first treat him with insulin, then you can shift him to insulin secretagogues, اللي هو oral anti-diabetic drugs. The third type is called severe insulin resistance diabetes, which account for 15% of the patient. دي مهمة. If you know that a patient has insulin resistance, this is very important for choosing a proper treatment. It's very important for expecting complication that is related to insulin resistance. Any patient, if you don't know that this patient has insulin resistance and you are treating him, for example, with sulfonylurea will make insulin resistance worse. It worsens the insulin resistance. The third type is called mild obesity-related diabetes, which account for 22%, and the last one is mild age-related diabetes, and this is the common type, which account for about 39%. So the step for novel treatment. Before you starting treatment, you have to estimate the pathophysiology, and this is based in the clinical and laboratory assessments. For example, the age. إيش أهمية to know the age of the patient? Because age-related type of diabetes. Because the age of patient with old age has a high risk of hypoglycemia. So you have to avoid your drugs which have a high risk of hypoglycemia. Because an old age patient has a high or some mild to moderate insulin resistance. Because one of the causes of insulin resistance is age. The third is increasing prevalence of obesity with age, particularly what's called the central obesity. ثاني حاجة assessment of the body weight by body mass index. But if the body mass index is less than 25 kilogram per meter square, the assessment is made by assessment of the waist circumference. So according to the body mass index or according to the waist circumference, in male waist circumference more than 102 cm is considered to have central obesity, and female more than 88 cm. So what is the importance of assessment of central obesity? Nowadays they classify central obesity into two types. One is called medically healthy obesity, and the other is called medically unhealthy obesity. A patient with medically healthy obesity should not be treated by anti-obesity drug, while patients with medically unhealthy should be treated by anti-obesity drug. Why? Because a patient with medically or metabolically unhealthy obesity has insulin resistance, has hyperglycemia, hypertension, dyslipidemia, visceral adipose tissue is increasing, liver fat content is increasing, and there is increased an adiponectin, which is called visvatin, and resistance. Also there is an increasing inflammation. So it's important to treat a patient with what's called metabolically unhealthy obesity. The adipose tissue is a big endocrine organ. It's important play an important role in the lipid metabolism by increasing activity of the lipoprotein lipase, with increasing free fatty acid, which are deposited in the liver, in the skeletal muscle, cause insulin resistance. It is deposited in the beta cell of the pancreas, causing lipotoxicity. It secretes other adipokines, which increase insulin action, زي adiponectin والleptin والvisvatin. But a patient with diabetes has adiponectin resistance. Nowadays, they try to produce a drug which is called adiponectin analogs. This is one of the noble drugs which be in the level phase of the production. In diabetic, there is a leptin resistance. The visvatin and our plasmin is decreased. الاتجاه الأيام دي إنهم يحاولوا to produce a drugs which mimics اللي هو الفسيولوجي of diabetes and not a chemotherapy. يعني بدأوا يجيبوا حاجة اسمها الأديبو كاينيس أغونيست أو اللي هو جلوكوز 6 فوسفات اللي هو agonist. Drugs which decrease insulin action, the tumor necrosis factor alpha, interleukin 6, and resisting cortisol free fatty acid. Drugs which has a vascular effect, substances, this cause endothelial dysfunction. The plasminogen activator inhibitor type 1, our angiotensinogen, our abiline, drugs which enhance substances which cause inflammation, substances which enhance immune response, and prostaglandin. What is the role of hyperglycemia? In a patient with type 1, what's called severe autoimmune diabetes, or a patient with severe insulin deficient diabetes, the main physiologic mechanism which is related to the long-term complication is hyperglycemia. Hyperglycemia enhances advanced glycation in product, increasing oxidative stress and cause hypoxia. This induces inflammatory signaling cascade with local activation of pro-inflammatory cytokines and inflammation. So there is increased risk of nephropathy, retinopathy and neuropathy. يبقى هنا في حاجة مهمة جدا. المريض اللي عنده just hyperglycemia زي those with اللي هو severe autoimmune diabetes أو severe insulin deficient diabetes. They are prone only to retinopathy and to the neuropathy. Like a patient who has obesity or insulin resistance is prone to develop a coronary artery disease or heart failure or others, chronic kidney disease or microalbuminuria. الأوتو antibody أهمية الأوتو antibody as we say there is a progressive destruction of the beta cell of the pancreas. Any patient with positive autoantibody should be treated with insulin. The autoantibody مهمة for staging and for prevention of type 1 diabetes and for choosing a proper treatment. The presence of insulin resistance. إيش أهمية إن أقول للمريض عنده insulin resistance؟ أول حاجة for staging and progression of type 2 diabetes. As you know, type 2 diabetes tomorrow in 4 stages. Stage 1, there is just insulin resistance. Stage 2, it is called insulin resistance. With dysglycemia, you have pre-diabetic stage. Stage 3, there is type 2 diabetes. And stage 4, there is already diabetes with complication. For choosing a proper treatment, a patient with insulin resistance, you have to avoid insulin, and you have to avoid insulin secretagogues because they enhance insulin resistance, and you have to choose drugs that improve insulin sensitivity and decrease insulin resistance. Expected long-term complications which are linked to insulin resistance. This as we said, the insulin resistances can induce hyperglycemia, can cause dyslipidemia, hypertension, microalbuminuria, hyperuricemia, and it can cause also endothelial dysfunction, inflammation, and oxidative stress. Also, it enhances beta cell dysfunction. So the insulin resistance is related to the complication which are induced by all these mechanisms, and this mainly the coronary artery diseases, with heart failure, with chronic kidney disease, with microalbuminuria. So what is the role of beta cell dysfunction when it's important for staging type 1 and type 2 diabetes mellitus, for subclassification of newly diagnosed diabetes, for choosing a proper treatment? It's very important to use drugs which cause a beta cell rest. They induce what's called beta cell rest. What's these drugs which induce a beta cell rest? Is a drug that decrease hyperglycemia because of lipotoxicity, drug that decrease the free fatty acid because of what's called hyperglycemia is a glycotoxicity, free fatty acid is a lipotoxicity. You have to use a drug that improves insulin sensitivity. You have to use a drug that decreases inflammation and oxidative stress. You have to use a drug that decreases apoptosis and enhance beta cell proliferation. So these drugs, what we call that induce a beta cell rest. The second treatment steps is determine an optimal A1C. The third step, you have to set an optimal body weight target. The treatment target is your weight loss about 5 to 10% of the baseline body weight, which is recommended as an initial goal for the treatment. The treatment indication, according to the ASE and ACE guideline, recommended that patients with diabetes mellitus and body mass index is more than 27 kilogram per meter square should be treated, and the patient with waist circumference more than 180 cm in male and 88 cm in female. The types of the treatment, diet, exercise, and drugs. You have to start with the oral anti-diabetic drugs which have a beneficial effect in decreasing body weight. This including sodium glucose linked transporter 2 inhibitor, أو اللي هو glycogen-like peptide 1 receptor agonist, أو dialpeptidase, أو to this extent اللي هو الميتفورمين. So the third, as we said, if the patient has severe body mass index is more than 30, you have to use other combined drugs زي semaglutide والliraglutide والorlistat and other combined treatment. طبعا في تهديد بالقطع. You have to do diet and exercise to achieve an optimal A1C and body target. You have to choose the drugs. If the diet and exercise fail to achieve optimal A1C and body weight target, these drugs يعني كلمتين مثلا عشان الدكتور ما يزعلش. You have to choose the drugs according to their glycemic efficacy. When any decrease in the A1C by 1 is associated with decrease of any diabetic related endpoint by 21%. Diabetic related death by 21% or cause mortality by 14, myocardial infarction by 14%, stroke by 12%, peripheral vascular disease by 43%, and microvascular by 37%. You have to avoid hypoglycemia because of their cognitive and psychological changes, accident, falls, and recurrent hypoglycemia and hypoglycemia unawareness, refractory diabetes, and cardiovascular effect of recurrent hyperglycemia, the cardiac autonomic neuropathy, cardiac ischemia, angina, and fatal arrhythmia. And if you have to avoid drugs that have what's called hyperglycemic issue or glycemic variability. What's the effect of glycemic variability? It can increase inflammatory marker and cytokinase with vascular inflammation, increase production of reactive oxygen species with increasing oxidative stress, impaired production of nitric oxide and vascular endothelial growth factor, leading to vasoconstriction. All these leads to endothelial dysfunction with thrombosis and increased plaque instability. This is the treatment actually according to the subtype. في هنا حاجة اسمها increased secretory capacity وهنا اسمها insulin demand. So in the first type what's called اللي هو severe autoimmune diabetes, the treatment of choice is insulin. The second type is severe insulin deficiency diabetes. You can start with sulfonylurea or with glinides, plus minus metformin. If this fails to achieve a glycemic target, you can start with insulin. The third type is the severe insulin resistance diabetes, and the most commonly related complication is escapade, heart failure, renal impairment, with diabetic kidney disease, NASH. These patients are the drug of choice for these patients actually. Nowadays, they say the drug of choice is the sodium glucose linked transporter 2 inhibitors plus minus metformin. They said you have to start with combined drugs including metformin plus sodium glucose linked transporter 2 inhibitor. If this fails to achieve glycemic target, you have to add glycogen-like peptide 1 receptor agonist. Thiazolidinidine should be avoided because of the fluid retention, which increase obesity and further insulin resistance. A patient with mild obese diabetes, actually this patient has a mild obesity, addition of metabolically healthy obesity, and a mild to moderate insulin resistance, and a mild to moderate beta cell dysfunction. So the drug of choice is biguanide, metformin, or sodium glucose linked transporter 2 inhibitor, or dipeptidase, or glycogen-like peptide if the patient, particularly if patient is obese. The 5th cluster is mild age related. This patient has a high risk of coronary artery disease and chronic kidney disease and has high hypoglycemic risk. So it's better to avoid a drug which induces hypoglycemia. You have to use drugs like biguanide or diabetes type 4 inhibitor. والسلام عليكم ورحمة الله.
شكرا جزيلا للاستاذ الدكتور محمد احمد بامشموس، والمحاضره قيمه جدا، اتمنى ان يكون لها ملخص حتى تستفيدوا، لانه هذه من المواضيع الحديثه والنيو كلاسيفيكيشن. الان ندعي الاستاذه الدكتوره بثينه الشرفي، هي احدى خريجات كليه الطب جامعه صنعاء، حاصله على الدفاع الاولى العام المركز الثاني، واخذت البورد الاردني في 96 ثم